when you have a case like this now there is exposed bone throughout this knee, and this is what we call tri-compartmental disease, meaning it's the medial, lateral, and the patellofemoral joint are all full-thickness cartilage loss. This is advanced tri-compartmental arthritis. And the gold standard for this has really been total knee replacement. And this has been a surgery that's been done for about 40 years now. And by and large, it's a very successful surgery, and it's really helped millions of people regain their quality of life and relieves their pain. This is so popular now. I mean, our country is facing epidemic numbers of knee arthritis. They're projecting, this to be over 1 million cases within the next few years, and by 2030, about 3 million knee replacements in this country alone. So it's a big economic burden for our country. But it's something that really does restore quality of life, and the government's willing to make that investment because it is such a helpful thing for people. And the newer techniques that we're doing in implants have improved outcomes and really made it easier for patients. Traditionally, it was a very difficult thing to go through, and it still is. But with our nerve blocks, or less invasive techniques, our therapy techniques, early mobilization, discharge to home, we're getting people back to their lives quicker than ever, and the recovery has been facilitated. With that said, total knee replacement is a major procedure with significant surgical and medical risks. And you have to realize that. The other thing that's important, as many as 1 in 5 patients after the surgery are either neutral about the procedure or they're dissatisfied with their outcome, which is a little bit concerning. As a surgeon, we don't really like to only make 80% of our patients happy. We like to make 100% of them happy, or as close to that as possible. So this number is what concerned me, and something I continue to see in my practice. You do the surgery right, everything comes out perfect, and the patient's still somewhat unhappy, whether it was an expectations thing or if there's some other underlying issue. It obviously is going to vary from person to person, but it's something that warrants consideration. But nevertheless, I'm not here to bash total knee replacement. Right now, when the whole knee is worn out, it really is the gold standard treatment option. It's something that's done throughout this country, and the main thing is if that's what you need to get your life back, that's what you do, and the odds are that you're going to get through it fine and be glad that you did it. But that 20% is what made me think, well, maybe as surgeons we can do a little bit better and offer things to our patients that maybe will provide higher satisfaction. And when I thought back to my training, I thought about unicompartmental replacements where just one side of the knee is replaced. And what I've learned is back in 1991 they did this study at the Brigham where I trained, and most of the patients they had a uni on one side and a total on the other. Most of the patients preferred the uni. And the more recent study from 2009, in this study people had a uni on one side and a total knee on the other. 52% of the patients preferred the unicompartmental to the total. The interesting thing is not one patient in that study preferred the total to the uni. So by and large, the patients preferred unicompartmental to total knee replacements. And really the benefits of this procedure now are pretty well established. It preserves the anatomy, the ligaments, the tendons, and the bone are all preserved in this operation, except for some minor bone cuts. It's less invasive, there's smaller incision, not that that's that critical, but it's not the incision, but what's done underneath that incision that's important. There's less blood loss typically, patients have less pain, a quicker recovery, which is very important to people. People like to get back in action as quick as possible. And better range of motion. These knees tend to bend almost like your own knee would versus totals, which we usually shoot for 110 or 120 degrees. And at the end of the day, we want our patients to be more satisfied, and by and large with these unis, they are. But I had my concerns about partial knee replacements and unicompartmental replacements. Traditionally, they were thought to have a higher failure rate. They were thought to fail earlier than total knees due to the loosening of the implants and due to the fact that, well, you're leaving parts of the knee behind so you can develop arthritis in the other parts of the knee. Well, those concerns are real, and I think a lot of them have been addressed, and I'll talk a little bit about that more in a second. But with some of these earlier designs, there's no question that they did fail. And the nice thing about it when it fails is you can convert it to a total knee. So you really haven't burned any bridges. the interesting thing, though, is that with the more recent studies, when we look at the more modern designs of these partial knees, is they've actually done very, very well. You know, in this study, 96% survival at 15 years of follow-up. This study, 100% survival at 12.4 years of follow-up. And this study, which is just from 2009, actually compared patients who had a partial knee to a total knee. And what they found at 15 years of follow-up, 90% of the partial knees were still functioning well, and only 79% of the total knees were still functioning well. So in this study, the partials actually outlasted the totals and actually outperformed the totals even at 15 years. So a lot of those concerns that I just spoke about may not in fact be true. Well, the other question is, well, how many people are really a candidate for partial? And obviously it's a great operation, but if only 5% of the people can get it, it's not really going to help most people. But what we know is that people who have disease of only one side of the knee is anywhere from about 5 to 20%. When you expand it to bicompartmental, meaning 2 out of the 3 compartments, you can get up to 40% of patients with that. I just did one of the bicompartmental this morning, and it's so true. You get in there, and just these parts of the knee are worn out. This side of the knee looks pristine, and all the ligaments and everything else are healthy. So you feel bad doing a total knee in a patient like that. So it's nice to have an option that's less invasive for the patient. Well, what are the options out there as far as partial knees? Because there's a lot of marketing now directly to patients. There's TV commercials and ads in the paper and everything. So when I looked at these things, there's one device called the Oxford, which was heavily marketed on TV. And it is a neat device. They've got some good track record out of England. The problem with it is it's a fairly limited device. It can only address that inside part of the knee. So if the kneecap is worn out or the outside of the knee is worn out, they don't even have a device for that. And at the end of the day, you're using off-the-shelf implants. And I'm going to talk to you a little bit later about why size of the implant matters. The Mako is something that's also very heavily marketed. This is a $750,000 robot which helps surgeons put in these partial knees. And the reason why that robot exists because partial knees traditionally have been an even harder operation than total knees. And so the robot, I think, is also a very interesting concept, and it does help surgeons put the implants in correctly. But at the end of the day, again, you're using off-the-shelf implants, which I think have their limitations, and I'll show you why in a little bit. So what we're doing here at JFK is we work with this company called Conformis, and they're a company out of the Boston area. And I think this has all the advantages of the partial knees that we spoke about, but it has some additional advantages. Number one, it's a patient-specific solution, meaning that every implant is made precisely for the patient, so it fits perfectly every time. It has uni and bicompartmental options, and soon we're even going to have a total knee resurfacing option. It's all pre-navigated, meaning that we don't need a robot or any computers in the OR because it's all been figured out ahead of time precisely how these fit, and they're made for you, so it's really just restoring the anatomy that's been lost. And it's the most conservative of all the implants, meaning it takes the least amount of bone, which is very important, and it has that idealized fit. So why does size matter? Well, people come in all different shapes and sizes, and so should their implants. A few years ago, one company created gender-specific knees. And this was it attracted a lot of attention in the industry because, well, it made us realize that people are different. I didn't think it was so simple as to characterize them as just as men and women, because as we all know, you can just look around the room and there's some women who are tall and slender and some that are short and stocky and some men that are like that as well. And you never know what implant is going to fit what person. So sometimes you'll be doing a gender-specific knee and you'll end up finding that the female knee fits the man better. And then how do you tell them that in the recovery room? It's not easy. So I'm sorry, sir, I have to give you a female knee. But what it means is that you can't really just create averages, because we all know that when you go to the store and they have small, medium, and large, some people are between a medium and a large. And the studies show that just 3 millimeters of overhang or underhang, meaning a little bit too big or a little bit too small, can lead to pain. If it's too big, it can irritate tendons and structures that are rubbing against the side. And if it's too small, it can sit on the soft part of the bone and actually fall into the bone and fail early. So I think that size is really important. And I think if you look at this slide here, these are all different inserts that are created by conformists for different patients. And you can see there's no way that you could stock all of these. Most implant companies have 6 or 7 different sizes at most. So I think this is really the future, is in personalization of these knees. So just right now, we have uni and bicompartmental options. So on this top side, you can see, okay, well, this inside of the knee is worn out. That's what it looks like on x-ray. They create this implant, and then we can put that implant in, and you can see the rest of the knee is left intact and it's healthy. When 2 parts are affected, it's the same thing. You've got the part of the knee here and then behind the kneecap. We actually create a device that just replaces those parts, and then this is what it looks like on x-ray. And this part of the knee is healthy, and all the ligaments and tendons are still your own.